The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon. On behalf of the Academy of Doctors of Audiology, I'd like to welcome you to today's webinar, Diabetes Educators in Audiology, Improving Patient Outcomes. My name is Cody Jones, and I'm pleased to serve as today's course moderator. Before we begin, I would like to turn it over to Dr. Kathy Dowd for a few announcements.
Thank you, Cody. Welcome, everybody. This is the second in our series of monthly webinars, and we're very pleased with the presentation today from an esteemed diabetes educator and audiologist. I want to say special thanks to the Academy for their in-kind donation of both the webinar service and the CEU offering for audiologists. Their staff support has been extraordinary. I have two announcements in advance. First, in April at AAA, April 21st, Saturday morning, we are going to have a free breakfast with the Audiology Project. We need volunteers. If you're going to be at the convention, please contact me. And secondly, our April webinar that's coming up will feature Dr. Pamela Allweiss at CDC, and she is going to be speaking about the PPOD tool guide with audiology. So we hope you can join us for that webinar. Back to you, Cody.
Thank you, Kathy. Hearing loss is a diabetes-related complication not typically addressed in education with people with diabetes. This webinar will increase awareness of this relationship and take action to assess and refer people with diabetes to an audiologist. During this session, we'll take the time to explain the role of the diabetes educator in educating people with diabetes on the disease of diabetes and the best ways to decrease risk of complications. We'll discuss how the educator and the audiologist can work together to provide reciprocal referrals. Just a few housekeeping items before we begin. First, please type your questions into the question queue and we will address them at the end of the presentation. Second, immediately following today's session, you'll receive an email containing all of the information needed to apply for continuing education credit through the American Academy of Audiology. All attendees will receive a general attendance certificate within 30 days of this course. Third, the slides from today's presentation will be distributed in the post-webinar email. Today's presentation is also being recorded and will be available for download on the ADA website next week. At this time, it is my pleasure to introduce today's course leaders, Joanne Rinker and Christine Pickup. Joanne Rinker is a master's level dietitian. She has her BS and MS in human nutrition from West Virginia University. Joanne has been a registered dietitian and certified diabetes educator for almost 20 years. Currently, Joanne is the AADE Director of Practice and Content Development. In this role, she works with member professionals as the liaison to the Professional Practice Committee. The Professional Practice Committee revises and writes position statements and practice documents in support of the profession. Additionally, Joanne leads the favorably reviewed initiatives in the staff liaison for the AADE Annual Meeting Planning Committee and is a staff content expert. Dr. Christine Pickup is a doctor of audiology and a person living with type 1 diabetes. She was educated at BYU with her undergraduate and master's degree and received her doctorate from A.T. Still University. She has worked in the field of audiology since 2000 in both private practice and in an educational setting. She opened her own private practice in Rupert, Idaho in April 2014. She is the only pediatric audiologist in the Mini-Cassia area and takes care of the hearing health of all ages. She is a wife and a mother to 4 children. When she's not running her clinic, she is usually in the kitchen cooking up something yummy, catching up on a book, or playing with fabric. She and her husband Westy built their home in 2012 and spend any free time working to put in the yard or finish another room in the basement. Please welcome Joanne and Christine.
Thank you so much. So this is Joanne Rinker. I'm going to kind of kick things off today, and then Christine's going to actually help me wrap things up. So first, I do want to say that I am working with American Association of Diabetes Educators, and today really I just want to talk more with all of you about how diabetes educators can help you, can help the people with diabetes who you serve, and others who have diabetes. So let's go to the next slide. So I want to talk a little bit first just about diabetes by the numbers, and it's because it's no doubt, I feel like we see this every day, that this diabetes epidemic is growing. And so, you know, you see the numbers here on the screen. It affects about 30.3 million people, million Americans, and about 84 million have pre-diabetes. And then, you know, and as overwhelming as those numbers are, the incidence of the disease is projected to double or triple by 2050. Diabetes is a major cause of heart disease and stroke, and as you see there on the screen, is the 7th leading cause of death in the United States. So what really sort of complicates these matters is that many people with diabetes also have multiple comorbidities. So those are things like hypertension, dyslipidemia, cardiovascular disease, and obesity. Next slide. So the interesting thing about this topic for me is that, you know, I didn't know the relationship between diabetes and hearing loss until I met Kathy, who was part of the introduction today. And so what she said to me one day, it was about 7 years ago, we were at an annual meeting for AADE, and she said, do you know about the relationship between diabetes and hearing loss? And I said, no, but I want to. So, you know, one of the things she talked to me about was just hearing loss in general and some basic facts. You know, 48 million people, which is about 20% of the population, have hearing loss. And then according to ADA, hearing loss is twice as common in people with diabetes, but also 30% higher in those with pre-diabetes. So this really got my attention. And let's go to the next slide. So Kathy then talked to me a little bit about a survey that she was conducting, or I feel like she was either in the middle of it or she was conducting it at the time. And she, you know, surveyed many diabetes educators in AADE. And what we found was that 49% of diabetes educators were aware of the relationship between diabetes and hearing loss. So 49% means less than half understood that this was even something that we needed to be paying attention to. 95% said that they rarely or never referred people for hearing screenings. 95%. So, I mean, we have this high number who are unaware, but we still have 49% who are aware, but they're not referring. Then we found 98% do not use any hearing screening tools. So it's not like, so even though they're aware, it's not like they're screening or doing any active way of kind of addressing this complication. And then when thinking about referral networks, 28% indicated that their referral network was actually good, 10% indicated excellent. But when you look at the rest of the data, you see that they weren't referring. So fast forward, so this, remember, this is 2011. So now fast forward to 2018. Kathy and I kind of, then now you can go to the next slide. Kathy and I kind of got together and we said, oh, sorry, 2017. We got together and we said, we really need to do this again because we need to see if the data has changed. So over the course of the year in 2013, I spent a lot of time traveling around different states in the United States and talking about this relationship between diabetes and hearing loss. And when we did this survey again, we got some great results. 95% of diabetes educators were actually aware of the complication. So to me, that awareness alone is probably the biggest first step, because then over time we know that these other steps they'll follow. But 76% rarely or never referred, but remember in the previous slide that was 95%. So that's already a big jump of people who are aware and are now referring for hearing screenings. 96% don't use any screening tools, but I really am not as concerned with that. I was more concerned that they were actually aware and then referring. So I felt like this was really strong outcomes that have happened over the last 6 years. And then referral networks are improving. 35 indicated a good network, 7% indicated an excellent network. So I really feel like this is a combination of Kathy's sort of independent crusade, because I feel as though she has been working on this since 2010, 2011. And then my small amount of assistance with sort of traveling around and trying to make more and more diabetes educators aware that there was this relationship. Let's go to the next slide. So just a few tidbits just about diabetes, because I think it's going to be important to just understand. There is type 1 diabetes, which are people with diabetes whose body does not produce insulin, and so those people are insulin dependent. Then there is type 2 diabetes, which there is sort of one of three, two of three, or all three things happening, which is they could have a runaway liver, which means their liver is producing sugar, but it doesn't know when to quit. So it may be producing sugar even when the person is eating. The person may have a pooped out pancreas, and that is a pancreas that should be producing the correct amount of insulin based on the amount of food the person is eating, but it isn't producing that correct amount of insulin. So it's kind of like this pancreas that's too tired to make enough insulin. Or they have insulin resistance, which means that the body is actually making enough insulin, but that insulin with glucose is not getting into the cells because the cells are resistant to allow that insulin with the sugar in. And so that's insulin resistance. So typically it's one of these three things, one or more of these three things are happening for people with type 2 diabetes. Then we also have gestational diabetes. So that happens for people that become pregnant. And then this is a hormone imbalance that causes gestational diabetes. Typically after the child is born, although the mother is at risk, at that time they typically don't have diabetes. And then of course prediabetes, which I mentioned earlier, we have about 84, 85, 86 million people with prediabetes. And let's go to the next slide. So what do we need to know about the need for diabetes education? Diabetes self-management training is covered by Medicare and most health plans. This is also a Healthy People 2020 priority. So the U.S. Department of Health and Human Service has made increasing the number of people who receive diabetes education a priority as part of their initiatives. So when you think about Healthy People 2020, they are looking, of course, they set very smart goals, so their goals have to be measurable. And so what they want to know is that more and more people in the United States are seeking out diabetes education, and that is the role of the diabetes educator. Next slide. So what are the benefits? Why do we want to make sure that when we come in contact with people with diabetes, that we are referring them to diabetes education? So research shows that people who have received diabetes education are more likely to do the following: use primary care and preventative screenings. So basically they're more proactive in their care. They are also more likely to take medication as prescribed. So just a fact I want to share is that 50% of people do not take their diabetes medications as prescribed. 50%. So I think that's a really important thing to note, because when we as a diabetes educator see that person, they come back to us, we have, the doctor has prescribed them a specific medication, they come back to us, maybe their blood sugars are still elevated, then we might say, oh, I wonder if you need a medication adjustment. But really the first question needs to be, are you taking your medication as prescribed? So seeing a diabetes educator and having diabetes education will increase the likelihood that they'll take their medication as prescribed. It also increases the likelihood that they will control their blood sugar that they will manage their blood sugar, their blood pressure, and their LDL cholesterol. Also have lower health-related costs, which of course are going to be important for us as a nation. Okay, next slide. So what is diabetes self-management education and support? And this is sort of a very true definition of the term. This is the ongoing process of facilitating the knowledge, the skills, and the ability necessary for diabetes self-care. This process incorporates the needs, goals, and life experiences of the person with diabetes and is guided by evidence-based standards. And let's go to the next slide. So there are two ways to know that a diabetes self-management education and support program is following the national standards. One is that they could be recognized by the American Diabetes Association, or the other is that they could be accredited by the American Association of Diabetes Educators. So if they are either one, if they are recognized or accredited, it means they are following the 10 standards, which are evidence-based quality standards for both structure of the program, the process, and how they evaluate outcomes. And if they are either recognized or accredited, then they are eligible for reimbursement by Medicare. Let's go to the next slide. So as I mentioned, that recognition or accreditation, it is showing that there is individualized evidence-based education that supports self-management for the person with diabetes. Also that it is an ongoing process. So typically initially, the role of the education is to assess the person with diabetes, to increase their knowledge, increase their skills, and then coach them to make behavior changes so that they can be successful and their outcomes can be improved. Next slide. So what kinds of things does diabetes self-management education and support do? It helps the person with diabetes make informed decisions. It helps them even with things like, when you think about informed decisions, to me that is things like making sure that when they are in a restaurant, they're making healthy choices. When they are faced walking into their place of employment and they can take the stairs or the elevator, they take the stairs because they're informed. They understand why their decisions are important and how to make decisions that are going to help them to be successful. Diabetes self-management education really helps to improve self-care behaviors. So those are things like meal planning, exercise, monitoring blood sugar. It also helps with problem solving and then active collaboration with an entire healthcare team. Next slide. So what are some of the goals of diabetes self-management education and support? We want to see improved clinical outcomes, of course. So those are things that we mentioned before. Management of blood glucose, blood pressure, lipids, A1C. But it's also improved health status, and really, to me, the best of this is to see improved quality of life. It's to see the people who come back and who feel better, who have been able to be more active, who aren't as tired, who maybe have been able to get a job, which they haven't been able to in the past. The success stories can be unbelievable because of improved quality of life, because of taking knowledge and being able to apply that to their daily routine. Next slide. So of course, when we think about the benefits, these are things that have been demonstrated: a reduction in A1C, a reduction in hospital and ER visits, and also a reduction in healthcare costs. Next slide. And then these are some of the big benefits that a person with diabetes may see over time because of that, taking the diabetes education and making it part of their real life schedule. So those are things like a 1% reduction in A1C, which is associated with many decreased risk. So it's 21% diabetes-related death risk reduction, 14% reduction in the risk of heart attack, and 37% reduction in the risk of microvascular complications. So I pause here because 37% decreased risk of microvascular complications, and it should say here eyes, kidney, nerves, ear, because it includes the ear here. So just be thinking of that as well when we're thinking about the reduction in risk. It's about 37% for people who have a 1% reduction in A1C, which is the benefit of diabetes self-management education and support. Okay, next slide. So in looking at this chart, I just put this in here because I wanted you to see kind of what's happening for people with diabetes. So 30.3 million people with diabetes, 84 million people with prediabetes. There's about 11 to 15 minutes that a person is spending with their primary care provider per visit. That's the primary care provider. That's why we see diabetes self-management education and support being so important, because it allows us the opportunity to spend a lot more time with them. Glucose management, payment for performance, these are all things happening in the current healthcare environment. Inpatient and ER costs for people with diabetes, hospital readmission reduction, that's what we want to see with diabetes self-management education. Microvascular health and wellness is improved. We talked about that. 37% reduction in risk. Multiple self-care and management decisions are made by the person with diabetes. And there is cost savings for that diabetes self-management education and support, which is either recognized or credentialed. Let's go to the next slide. Here is the thing that I question. How is this possible? There is such low utilization of diabetes self-management education and support within that first year of diabetes diagnosis, which is really when in a lot of cases it is most important. So what we find is about less than 7% of privately insured beneficiaries take advantage of this coverage. And for Medicare beneficiaries, it's about 5%. Let's go to the next slide. So what is so important about this? So I wanted to kind of go over some of the data that's on this slide. First of all, Medicare provides reimbursement for diabetes self-management 10 hours for the first year and then 2 hours for each year after that. For medical nutrition therapy, which is something that the person with diabetes could have in addition to diabetes self-management education, they have 3 hours in the first year and 2 hours for each year after that. Referrals are always required, but they're easy to make. So that is why that is a covered benefit. What's important to note is that diabetes is a complex and burdensome disease. So it requires the person with diabetes to make numerous daily decisions regarding food, physical activity, medications, monitoring. This program, Diabetes Self-Management Education and Support Programs, they facilitate the adoption of those skills because they provide the knowledge and the skills, as well as helping the individual identify barriers and facilitate any problem solving and coping skills so that they can make behavior changes. So keep in mind, this is kind of the amount of time or the amount of more time that a diabetes educator could actually spend with a person with diabetes that their primary care provider cannot. So keep that in mind. Okay, let's go to the next slide. So we talked a little bit about this underutilization. Very few people with diabetes actually receive diabetes education. You see there it's about 44% who have, 56% who have not, but keep in mind, this is diabetes education as like a big umbrella. So this could be diabetes education that is done in 15 minutes with a nurse in a provider office, which is very different from the data that I showed you earlier, which was, 7% are taking advantage of diabetes self-management education and support, which is either that accredited or recognized program. The good news is that people are getting some sort of diabetes education, but what we want is to see that it is this structured education, that it's clinical, that it is evidence-based, and that it is going to get them to the point where they can lower that A1C by 1% and see those risk reductions. Let's go to the next slide. So what do we see? What does the research actually show? People with diabetes don't always follow through on referrals. They are emotional because they are very surprised and shocked when they are diagnosed with diabetes. They do look to a support system. So they look for family and friends. And in the beginning, and maybe even over time, they think that they actually know enough to be able to handle this on their own. Providers know the importance of diabetes education, but they don't necessarily prescribe or refer to diabetes education. And they sometimes forget to follow up with people with diabetes to encourage their attendance. So this was an actual, these results are actually from a study that was done by the American Association of Diabetes Educators with both healthcare providers and with people with diabetes. So this is what we're finding. And so that's why it's so important that we then took the next step. And let's go to the next slide. So the next thing we did is we said, okay, we need to make sure that providers understand, not only providers, but people with diabetes as well, understand when it is most important for people with diabetes to be referred to a diabetes educator. So that first time, and this doesn't need to be in any specific order, but these are the times when people should be referred: at diagnosis, annually, when there's any complicating factors. So this would be, let's say, if we refer to the audiologist and we find that there is hearing loss, that is it. Or if the provider refers to the audiologist and we find that there is hearing loss for a person with diabetes who has not seen their provider, then this is a time not only to refer to the provider, but also to be referring to diabetes self-management education and support, because there's an indication of a complicating factor. Also, when there is transition in the care that occurs. So this could be transition from pediatric to adult, from adult to geriatric, etc. Any transition in care that's occurring. Let's go to the next slide. So keep in mind that this is just showing a little bit more about that algorithm. We talked about the 4 critical times that people should be referred to diabetes education. The focus and the action needs to be on that primary care provider referring to diabetes self-management education and support programs or diabetes educators. So these are the main things to really think about. Let's go to the next slide. So as far as treating people with diabetes, managing diabetes can be overwhelming for people, and therefore it's complicated, it's time consuming. It really adds to the demand on the practice for a provider who has a lot of people with diabetes. For each person with diabetes, they're faced with balancing their priorities and their goals. So they're choosing which problem is most urgent, and then the diabetes educator is trying to help them manage their disease along with any possible comorbidities. So it's really important that diabetes educators are part of this step to help empower and enable people with diabetes to be able to balance their priorities and their goals. Let's go to the next slide. So when you refer a person with diabetes to a diabetes self-management education and support program, or to their provider and encourage their provider to refer them to the program, these are kind of some of the things that the educator and the program is doing for that person with diabetes. They're helping the person to improve their outcomes. They're helping to delay the onset of diabetes if this is a person with pre-diabetes. They're helping them to track and monitor their progress, because it is evidence-based that if they can see progress, if they can see improvement, that they will continue to do that progress and improvement. They will also reduce their blood pressure and other outcomes, which we'll talk more about. They'll increase their efficiency, and they also the provider meets pay for performance and QI goals. Let's go to the next slide. Also, the diabetes educator can help develop self-management skills for the person with diabetes. That person can achieve better metabolic control. And so the metabolic control is the things like the blood lipid levels, the blood pressure, BMI, kidney levels, things like that. So it's really working with them on all aspects to really partner that diabetes educator with that person with diabetes to see these improvements. Okay, let's go to the next slide. So when you make these referrals, I want you to know who the diabetes educators are. So in large majority, it's a registered nurse, it's a registered dietitian, it's a pharmacist. But there are also a lot of other professionals who are very passionate about diabetes and who work with diabetes, who do diabetes education, who may have become diabetes educators. And those are people like nurse practitioners, physical therapists, exercise physiologists, social workers, health educators, physicians, and podiatrists. So I want you to kind of think about who those possibilities are that you may be able to develop relationships with in your community, because all of these people are seen as diabetes educators if they have that passion for diabetes education. So let's go to the next slide, because I want you to see what kinds of things the diabetes educator actually covers. So the diabetes educator will cover the 7 self-care behaviors. So those self-care behaviors are healthy eating. What and how often that person eats really affects their blood sugar. A diabetes educator can work with the person with diabetes to read food labels, count carbohydrates, understand portion sizes, and really make choices that work for their taste, their schedule, their lifestyle, those kinds of things. The next one there is being active. So being active has many health benefits, from lowering blood sugar and cholesterol to easing stress. So the diabetes educator really helps the person find ways to move more throughout the day, as well as find activities that really help to increase their heart rate, but also that they are things that they will enjoy. So those are really priorities. The next there is monitoring. When a person has diabetes, their body doesn't properly manage blood glucose, which is the main source of fuel. So a diabetes educator will show the person how to use a blood glucose meter, record their blood glucose, and then figure out what to do when the numbers are out of their goal range, okay? The next there is taking medications. We talked a little bit about this, but really the diabetes educator is going to help the person with diabetes understand how to take their medications as they are prescribed, and also they're going to help them understand why that specific medication is going to be helpful to them. The next one is problem solving. Even when a person plans their day, unexpected things happen. So the diabetes educator can really help them figure out how to deal with those unexpected things when they come up. And an example of this really, I think about children. Every day for them is different. They walk into school. If it's pouring rain that day, they may sit and watch a movie in a specific class, but on another day in that same class, they might be going outside and running around the entire time. So you think about how hard it would be to help them to manage, well, for them to manage diabetes without the guidance of a diabetes educator. So often that's something I think about when I think about problem solving. Healthy coping. So it's really hard for people with diabetes to avoid stress. It's important for them to know how to cope. A diabetes educator can really help them to identify any difficulties they face. Also, they really provide support and encouragement so that they can come to them and talk to them about concerns, or the diabetes educator has a network so that they can refer them if it is something that needs more elaborate attention than the diabetes educator can provide. And then lastly, there is reducing risks. Taking control of their diabetes will really help them to reduce complications. So that diabetes educator can help them to make staying healthy easier. And that's going to be things like referring them to the audiologist, referring them to the eye doctor, etc. So let's go to the next slide. So let's talk a little bit specifically about that, because what we know is that there are specific factors that are going to increase the risk of hearing loss for the person with diabetes. One is going to be their age. If they're 60 years of age or over, it's going to increase their prevalence. Another is their duration of diabetes. So if this person that we come in contact with has had diabetes for 30 years, then their risk for hearing loss is going to be a lot higher than the person who's had diabetes for 1 year, 5 years, that kind of thing. Also, diabetes is associated with hearing loss and could aggravate the hearing loss related to age. And then lastly is actually increased BMI. We find that increased BMI for people with diabetes also increases their risk of hearing loss. Let's go to the next slide. So how do we reduce this risk? So the way to do this is two things. We want to help them to manage their blood sugar, and then we want to help them to manage their blood pressure. So those are the two things that are going to be the biggest. So the diabetes educator really works with them to help with both of those things. Let's go to the next slide. So here we want to think about, what does the diabetes educator actually do? We teach, we coach, we guide people with diabetes, beginning with helping them learn about diabetes, including what it is, what are the causes, what are the risks of not managing it properly. We really help them understand the best ways to use their monitoring devices, whether it be their meter, pumps, pens, CGMs, different things like that. And we really help them to assess what are the choices, what's the timing, what's the frequency of testing, all of those kinds of things. We also can explain how they can adopt healthy eating habits and make some changes to their diet and their lifestyle. So that's including things like meal planning, weight loss, but also any other disease-specific nutrition counseling. So, they may have things like celiac disease or, other things that may make this even more challenging, but that diabetes educator can help to reduce those risks and decrease the challenge. Let's go to the next slide. Also, the diabetes educator is really going to help, like we talked earlier, with problem solving and stress management skills. And oftentimes, this is a big part of one of the things that they do during the 10 hours of the classes that are done in that first year. There's actually time that's taken to do some of those stress relief activities that the person with diabetes can then do at home when they're by themselves. Also, monitoring blood glucose and interpreting and responding to that data, and then really understanding how medications work. Let's go to the next slide. So how do you find a diabetes educator? So one way to do that is to really think about broadening your network. Think about the people that are in your community. What are the provider offices? They might be like standalone offices, outpatient centers. What hospitals are in your area? Do you have a public health department? So most counties will have a public health department, or sometimes there are districts where there are multiple counties that have one health department. But look into that, because many of those now are starting diabetes self-management education and support programs. Also, they work in private practices, so maybe with endocrinologists, if you have endocrinologists in your area. They might work in clinics like free clinics or community care clinics, things like that. And then, of course, like I mentioned, sort of like standalone physician practices. So these are places that you can find a diabetes educator. Let's go to the next slide. Another place as well is that if you look at the two organizations, the American Association of Diabetes Educators or the American Diabetes Association, you will find that there are ways there that you can go to their website and you can find a diabetes educator. So those are some things to consider and to think about if you want to use your zip code to be able to locate where there is a program or an educator near you. Let's go to the next slide. Another thing too is how can you take action? If you were to join and become a member of the American Association of Diabetes Educators, there is a state coordinating body listserv, and on that listserv you could post information about your region in the state so that you can say where you are an audiologist, and that will really help the people that that are diabetes educators in your area reach out to you, and then for you to be able to reach out to them. So that really is a way to have that reciprocal relationship and be able to make those reciprocal referrals. Also, learn more about your state's Diabetes Advisory Committee. This is in each state health department, so this could be more convenient if you happen to live closer to the capital of your state, but you could still play an active role in any annual meetings they might have or conference calls and things like that. And then also, sort of like I mentioned in the previous slide, just reaching out to the local diabetes educators that might be in those other settings so you can build relationships and referrals. Let's go to the next slide. So now I want to bring Christine back. We introduced her much earlier, but she's going to actually wrap this up by telling a story about her own personal experience, because she is a person with diabetes as well as an audiologist. So I feel like she can really kind of bring this all together, and then we'll go ahead and let her field any questions that both her and myself can answer. So Christine, I'm going to turn it over to you.
Thank you, Joanne. First, I want to tell you how much I appreciate your perspective. My diabetes educator was incredibly impactful in my life when I was first diagnosed. So a little bit about that. I was diagnosed at age 37, and because of my age, they assumed that I had type 2. So I went 3 months with taking a lot of oral medications, exercising my heart out, cutting carbs out completely, and still struggling with my blood sugar. So I was doing everything right, but it wasn't working. And finally, my primary care doctor had the wisdom to say, I don't know what's going on, let's find out someone who could. And through his wisdom, I was referred to a diabetes specialist. I had to travel 70 miles away from home, and was finally given the correct diagnosis, and I started using insulin in November of 2012. The thing that I want to really impress upon everybody's minds is that diabetes is something that is always in the background of your mind. It's kind of this drumbeat that's always running. Where is my blood sugar at? Did I take enough medicine? Did I eat the right type of food? Did I compensate properly? How is my exercise going to affect what happens today? It's kind of this moving target that one day it works perfectly, the next day everything's wrong and nothing works. And so when you're working with people with diabetes, be understanding and compassionate. Don't judge them if their A1C is higher than it should be, or don't judge them if they're making what you perceive as poor decisions. You don't know what's going on behind closed doors every day. And for some people, it is a tremendous difficult task that they have to try to get through every day. Trying to be your own pancreas is a really hard thing to do. There are a lot of parallels between diabetes and hearing loss. they're both chronic conditions that are managed, not cured. I've learned a lot of empathy for other diabetics, and then just understanding other people that deal with chronic conditions. It is a really hard thing that you have to do on a daily basis. Tech and tools are expensive, just like in hearing healthcare. I wear an insulin pump and I use a continuous glucose monitor, and they have made my life with diabetes so much better. I had a little incident about a month ago where my glucose monitor went on the fritz, and at the same time my pump did. And so within a matter of 2 hours, my blood sugar went from normal to over 400, and I was quite sick. And it happened that fast. And so I'm very dependent on my tools, just like our patients, we hope, are dependent on their hearing aids. I understand that diabetes is a carbohydrate metabolism problem, and it's not just sugar. That was a misconception I had when I was first diagnosed. It's not just the sugars you eat, it's any form of carbohydrate. And in my case, it's even protein that I eat. My body's really good at turning protein into sugar, and so I have to compensate for the protein I eat with insulin as well as for the carbohydrates I eat. Those first couple years were really difficult, learning how to manage, learning the change that it made in our family, the emotional toll that it ran, just learning how to get through it. I struggled with depression. I had some anxiety for the first couple years. It adds a lot of stress to families. And then you add hearing loss on top of that, and that can be a lot to handle. So I love the idea of reaching out to our diabetes educator colleagues. We need to quit seeing people in parts and pieces and see them as a whole person. I'm really, it's funny to say, but I'm grateful for my diabetes because it's taught me a lot of empathy. It's taught me how to see things differently. And I wouldn't wish it on anybody, but I'm grateful for the tools that I have, and I'm grateful because it actually was my motivation to start my own practice. It was my motivation to make a lot of changes in my life, and I wouldn't be who I am today without it. Now, I guess, do we have any questions?
Yeah, thank you, Christine. So I guess we're at a point where we can see if we have questions.
Yes, we do currently have a few questions. And as a reminder, if you have any questions, go ahead and type them into the question queue. We got about 13 minutes to do Q&A, so I'll get to it. The first question is, what is the mechanism or physiology of the relationship between hearing loss and diabetes? How and why does diabetes cause hearing loss?
Okay, so there's a couple ways, or there's a couple things that could be going on. First is that for people with diabetes who have elevated blood sugar, and I just want to kind of like use this visual first so that you can think about it this way. If their blood sugar is elevated, then it means that their blood is actually, it is very thick. And so it isn't flowing through the bloodstream like it should. And so what happens then is it doesn't get to places like the tips of their fingers or the ends of their toes. And so now let's think about the ear. What's happening is it's not getting into those very tiny blood vessels in the ear. And so then what happens is that the blood vessels start to break. And so that's kind of one aspect of it. There's also actually some effects that the elevated blood sugar will also have on the nerves. So it's actually having an impact in the messages being sent from the ear to the brain. So it's actually kind of two things that are happening there, but both of those are the result of elevated blood sugar and elevated blood pressure, which is why when we think about the relationship and we think about how we can prevent the risk, we think about trying to manage both the blood pressure and the blood sugar.
And just to jump in, that's why that blood sugar management is so critical. If we can keep blood sugars in a normal range, you're not going to have those complications. I worked really, really hard to keep my A1C under 5.5, which is near normal range. And my doctor tells me that I shouldn't have any complications if we can keep it that way. And that's something that's doable for diabetics if we can get them the tools they need.
Thank you. The next question. Are there statistics related to prevalence of tinnitus and/or increased risk of tinnitus associated with diabetes?
Kathy, do you know those numbers?
No, actually, I am not familiar with the incidence of tinnitus with diabetes or hearing loss associated with diabetes. So that would be something that we should look up. There's
Yeah,
new things.
we could look it up, and if there's a way to post it or to maybe send that data to this group. I don't know if there's a mechanism for communication with the group, but that might be something we could share after.
Well, there is a Facebook page for the Audiology Project. So if I find anything, I will certainly post it. And if anybody else finds it, certainly you can post it if you like and follow the Facebook page. That would be super. The more we learn, the more we can educate other people.
Yeah, perfect. That's a great question. Thank you.
Okay, thank you. This next attendee stated that she contacted a local diabetes educator and they're confused and slightly put off by her initial contact. Do you have a recommended approach or specific questions to use?
Well, that's interesting. One thing I would do is maybe bring some of this data with you. I mean, we have very specific data about the fact that there is a relationship between diabetes and hearing loss, and that this should be a reciprocal, sort of a reciprocal referral. And so it may actually help to do something, to print off some of this or all of the slides and say that you had attended a webinar on this topic and the importance of having that relationship and building that relationship with the diabetes educator.
And I would just say that there's still a lot of diabetes educators and other medical professionals who are unaware of this link between diabetes and hearing loss and diabetes and risk of falls or balance issues. So this is what we're trying to do, is to advocate and raise awareness. This is a process.
Thank you.
Mm-hmm.
Christine, this next question is directed towards you.
Okay.
What were the symptoms you experienced in the beginning before you were diagnosed?
Good question. So I had a lot of things that were off but weren't really specific. And the main thing that actually got me into the doctor's office was I had a sudden change in my vision. So it was a summer where we had a lot of fires in our area. My allergies were horrific and I just wasn't feeling well. And I laid down to take a nap to see if I could start feeling better. I woke up and my eyes, I couldn't see through my glasses. They actually changed a full diopter. My vision did. And that was my first real big symptom. And I put it off for a couple days thinking maybe I'd screwed up my glasses or something. And when things didn't get better, I got into the first ophthalmologist that I could see on Monday. And his first question was, do you think you could have diabetes? And I laughed. I said, no. There was no family history at all. But it turns out that my blood sugar was over 450, and what he thinks is that I had a big spike, like over 800, and that's what caused the change in my vision. I'm very fortunate. I've never had diabetic ketoacidosis. I've had really good blood control management from the very beginning. But that was actually my first symptom, was my vision changed.
Thank you. The next question. What do you consider is the proper way to manage a diabetes patient evaluated in an audiology clinic for the first time?
So are they, I guess, the first thing we'd have to know is, are we already aware that the person has diabetes? And then it would be, have they seen a diabetes educator? And if so, could the two of you really have some conversations about what are some things that they are working on, you know, how can you and the diabetes educator maybe work together to see some outcome improvements for this person. But, you know, I think it's the awareness, just knowing that they have diabetes, being able to ask them about their management of diabetes. You know, are they receiving education? Are they actively following up with their provider? Are they taking medications as prescribed? I mean, just, I think anything that's going to help to support them with their self-care would be really key if you're, you know, if the audiologist is seeing someone that not only is there because of, you know, any issues that they're having with hearing, but is also there because they have, but it also has diabetes.
And absolutely encourage them. You know, when you show someone support, you show that you are aware of the difficulties that they're facing and that you're there to help them. So the more that you can, you know, talk to them about how they feel about it, talk to them about what, you know, how they're managing, what their plan is, and see how you can kind of support them in that plan. And whether that is making a referral to an educator if they haven't been to one, talking with their primary care doctor about what your role could be in helping them, all of that helps.
Thank you. Do you have a concrete recommendation for how to counsel a patient with hearing loss and diabetes?
Well, it's you know, there's 7 healthcare behaviors, so it would be hard to say that there would be one specific thing to say or do. But if I was going to say one thing, I would say to ask them what their biggest concern is. Because it shouldn't be an agenda that we have necessarily. It should be, what is their agenda, and what tidbit of knowledge is really going to help them for them to be the most successful. So, I mean, if I would say if you have a person with diabetes in your office and you know that they are not necessarily managing their diabetes very well for whatever reason, just asking them, what is it about diabetes that concerns you the most? Because a lot of times that'll go a much longer way than us having an agenda with them and wanting to talk to them about their meal plan or about taking their medication or about getting some exercise. It may be lifting a burden for them in another way. So I think, and maybe what you find out is that it's all about their hearing. And once we can, you know, help them to hear again, that actually might improve their diabetes by leaps and bounds because it helps decrease depression, etc. So.
Thank you. Christine, I have a follow-up question to what you're discussing earlier. Was the change in vision you mentioned permanent?
No, thankfully it wasn't. Once we got my blood sugar back under control, my vision actually improved. I've always been nearsighted, and my prescription actually got better after my vision settled down. I had to get new glasses and everything. So thankfully it wasn't a permanent change, but it was definitely a wake-up call. My first thought was that I had a tumor. You know, diabetes wasn't even on my radar. It wasn't something that I thought of on a regular basis at all, and that's completely changed now.
Thank you. We have time for one more question. What do you attribute the 50% non-compliance of diabetes management?
It's not diabetes management. It's 50% of people with diabetes. And this is actually 50% of people with 50% of prescribed medications, but I have seen it in the literature specific for people with diabetes as well. Just don't take their medication as prescribed. So that doesn't mean it's 50% aren't managing their diabetes, but there are 50% are not taking their medications as prescribed. And what do I attribute that to? I attribute that to things like, you know, maybe they're still in denial when they are first prescribed that medication. I attribute it to things like, you know, this is really hard to remember to do every day. so it's all of those things. It's the fact that this is overwhelming and that it's something they have to remember to do every day. It's cost. There's a huge list of reasons why it's something that's not happening. But just sort of as an FYI, it's more than just people with diabetes. It's people who are prescribed medication, period.
Thank you. And we are out of time for today's session. If you have additional questions, please email them to info@audiologist.org, and we will post the questions and the answers back to all the course attendees. And as a reminder, course attendees will receive an email containing a link which will allow you to complete CE information and your assessment and your evaluation. In addition, we will also send the PDF version of the slideshow that was used today. If you have friends and colleagues that were unable to attend the webinar, please let them know that it has been recorded and it will be posted to the members-only section of the ADA website next week. For more information about future ADA initiatives, please visit www.audiologist.org. Thank you and have a great rest of your day.